Thanks.
Good morning, everybody. Can you hear me okay? Okay, we're gonna run through roll really quick and I'll pass it back to Maura. Is Dharma here today? No Dharma. Blue?
Here.
Great, thank you. Mariah?
Here.
Thank you. Janine? And Janine, Eric? Eric Swackhammer?
I'm here.
Good morning. Haven?
Yep.
Thank you. Jenna?
Present.
Thank you. Adam?
I'm here.
I saw you there. Cool, great. Claudia? And Claudia. And then Amy is here, but she has to attend to something. And then Serafina, Julia.
Yes, Serafina, present. Good
Thank you.
morning.
Morning. And Crescencia.
Present.
Great. Did I miss anybody? Okay, back to you, Maura.
Awesome. Thank you so much, Ashley. So I am actually going to pass it over to Annalise to give us some director's updates.
Thanks, Mara. Can everybody hear me okay? Awesome. Okay, Annalise Dolph. I'm the director of the ADPC. I think everybody knows me. My usual updates from the other committees and the commission, and some exciting news from the settlement board. Recovery has been meeting the past couple of months to come to terms with a definition of recovery community centers. And this past month, they worked with OYA, the Oregon Youth Addiction Alliance, to develop best practices for recovery community centers for youth, which is a nice collaboration there, and began discussing measures, how we want to measure outcomes from recovery community centers over time. The treatment team has been focusing on a treatment provider landscape survey that they're going to be doing this Friday, or not this Friday, this fall, to get a baseline to measure over the course of the comprehensive plan. And then in July, they're going to start to turn to discharge and transition from treatment and options, barriers, ways to streamline that. The Primary Prevention Committee has been working for the past several months on developing recommendations for the scope of a primary prevention center of excellence in Oregon, and they will start turning this summer to governance of such a center of excellence. The commission met last month in June, or this month, sorry, I'm all sorts of in transition right now. In June, we met at the Miracles Club and continued a conversation we've been having about frameworks for measurement, using existing frameworks like recovery capitals, social determinants of health, positive youth development. It's been kind of fun. And then in July, we meet July 13th, and we'll be giving a Q2 update. So they're going to be hearing something similar to what you all are going to be talking about today. Oh yeah, did one a couple weeks ago to really evaluate where we are with the first 6 months with the plan, which is pretty exciting. And then finally, the settlement board, just wanted to give an update there. I think I reported out last month. The OHA is developing a request for grant applications that should hopefully be up and available to the public this fall. And we are doing a pretty cool exercise to map the approved uses of settlement board funding with the comprehensive plan. So taking the strategies and activities that you all came up with for the plan, as well as the rest of the continuum, and really mapping them to approved uses for the funding. The direction the board has given to OHA so far is that they do want to have allocations across the continuum. So they are very much hoping to get grant applications from everywhere, including from harm reduction providers. So that's been a nice opportunity to bring forward some of your ideas for funding. It is one-time funding and only about $13.5 million. But the settlement board, after this round, will be turning later this year to look at allocating funding over the next decade. Most of the settlements are settling out. We're getting our schedules for all of them. So we'll know about how much money we'll have as a state over the next decade. So pretty exciting stuff and how your work then translates over there. That is all of my updates. Let me know if you have any questions.
David has a question.
Sorry if I missed this, Annalise. When did you say you think the RFP is going to be dropping for that?
This fall.
Awesome. Cool. Thank you, Annalise. So if there's any more questions for Annalise related to her director's updates, or if you think of something later, go ahead and shoot me a message and I will get that to her. So I wanted to share a couple of updates with you. If you can see the agenda up there right now, and this is more for our agency partners, we thought it would be a good idea to let them share after our discussion portion of each meeting. So we've built in a little agency partner update space towards the end of the meeting. So our agency partners can share updates from their perspective with you. So agency partners, be prepared if you would like to share anything after we're done with our comprehensive plan update. Secondly, we have spent the last almost 6 months talking almost exclusively about naloxone. We did a little bit of cleaning up of our charter. We did a little bit of like rules making and a couple of other things. Who are specifically so an agency partner is anybody who is representing an agency who is not a voting member. So OHA, OSP, our state agency members. Yes, state agency partners. Thank you, Annalise. So we just wanted to do a little bit of an update on where we are and sort of look forward about where we're going because it is 6 months since the plan started, and we wanted to get things sort of get ourselves back in order and look forward to the outcomes that we're trying to get to. So if you could go to the next slide, Ashley, please. Oh. So I wanted to ground us in where we started. So when we developed the comprehensive plan, this was the naloxone strategy that we developed together. So our naloxone strategy was to develop and fund a statewide strategy for the purchase and distribution of short-acting overdose reversal medications, such as naloxone, which will ensure access in rural areas and include education strategies to ensure proper administration and dosage during overdose emergencies. So that was the overarching strategy, and there were 3 activities that were listed underneath this strategy, which was to promote greater use of Oregon's bulk purchasing system, which we know as MCAP, by state and local agencies, public health departments, and community-based organizations to reduce cost and increase supply access. It was to support increased distribution opportunities through other existing channels, including Save Lives Oregon, the clearinghouse, pharmacies, and other access points, by issuing statewide guidance brief on all the access points for naloxone for individuals, organizations, and agencies, and to encourage more naloxone distribution in communities with low access by coordinating outreach, reducing barriers, and providing messaging tools, including distribution of statewide guidance briefing, focusing on underserved communities. So I know that was a mouthful, and that was, I sort of wanted to ground us in this because we've had a couple of conversations where we've said, I think we've gotten sort of lost in the weeds with either opportunities to intervene or barriers. And so I think I wanted to bring us back to where we came from and point us in the direction of where we're going. and give you an update on some of the work that we have done both together and that Stacy and Annalise and the ADPC team have been doing behind the scenes. So this was Stacy's great idea to put this all based on the strategy or the activity. So if you could go to the next slide, Ashley, please. So here is the progress as listed by activity. So by promoting greater use of Oregon's bulk purchasing system by state and local agencies. So I have had conversations with quite a few of the state agencies, and there are some discussion moving forward with both ODHS and OLCC. So they have interest in more naloxone and or policies to support naloxone distribution. So there will be more to come with that once there are further discussions. I have a discussion with OHA and ODHS coming this month. And I also have some conversations with OLCC. I have some ideas about what could be how OLCC could improve access to naloxone, but there's all sorts of ideas floating around, so that is exciting there. As Annalise has mentioned in the past, we have completed, well, almost, we are almost done with our financial analysis of biennium 23-25. And we had looked at naloxone spending. We had asked agencies to separate out their naloxone spending. So that will be a really exciting metric for us to be able to share with you when we are finished with that. I believe September is when we can come back to you with the financial analysis, but there's some pretty cool data and information in that financial analysis that we're looking at right now. So that will give us more background information about where naloxone is going and where it's coming from within state spending within the state agencies. So that's exciting. As many of you were here, is that going to be a public report? Sure is, Haven. It is going to be a public report. We are giving the draft to the governor's office this, I believe, next month, July. Yep, July. And then after we clean that up from their suggestion, then it will be a public report in September. So we will come and share it with you in September, and then it will be out in the world at that time as well. That's a great question. As many of you were here, we connected directly with MCAP. So our friend Kim from MCAP came and shared with us how MCAP works, how many folks can connect directly with MCAP, and there was a lot of really great connection that went on through there. And they also shared with us their data from their perspective, from their side. So they said, here's the spending that we've received directly through MCAP. And we were able to break it down by this has gone through Save Lives Oregon. This is folks in Oregon who have a direct MCAP account. So we have a lot of data that is going to keep pushing us along with this activity. And then finally, the Rural Health Transformation Project within OHA has been doing some naloxone work. I have a meeting with them, and I will potentially, depending on how large scale their project is, I will have them come in. RHTP is the Rural Health Transformation Project, and that is federal funding intended to help rural communities move projects forward in their communities. Yeah. They depending on how what the scale of all of their naloxone work is, I may have them come chat with y'all to see if we can provide them any input. If it's just something smaller, I'm not entirely sure what the scope of it is yet. I will just continue to check in with them and bring you updates from them periodically. So more to come on all of that. That is that was my progress report on the first activity. While I was, personally, while I was going through this and making these updates on this progress, I was much more bolstered than I felt before I went through this. Uh, Before I went through this individually at an activity level, I was feeling like, wow, I feel like we haven't really gotten anywhere. But when I went through this, I was like, wait, we're getting places. We're getting places. We've got plenty of stuff going on. So, are there any questions on this activity? I've been seeing some questions in the chat, trying to answer those out loud if I can. All right, then looks like we can move on to the second activity. Beautiful. So our second activity was to support increased distribution opportunities through existing channels and including Save Lives Oregon and other places by issuing statewide guidance. So that to say, we have brought this up, Stacy brought this up, I think the last time we met, where we sort of went through where did we come from, where are we going, what are the opportunities to intervene, and where are our barriers. And so we sort of settled on this idea of a naloxone toolkit. And this was, as you can see, written into this activity. And all of this moving forward, I want to let you know that next month we will be building that toolkit together. So there will be a little bit of homework that I'll go over with you prior to that. But we've got some stuff, I've got some stuff in the works as well to bring you sort of like a skeleton of this toolkit that we can then work on together. So that is progress there. And then in August, Save Lives Oregon is going to come and give us like some brief overview of some of their data that they got from their survey that they do for their participants. And we're gonna hope that I know that they got a lot of data, and so we're gonna see what they have to say about how that affects our work, our toolkit, our policy work, things directly connected to the ADPC. So that is our statewide guidance brief progress and some of the stuff related to the clearinghouse. We've been working really closely with Save Lives Oregon and Jude, obviously. So that is that. Anyone have any questions about this? No, great. Next one, please, Ashley. Beautiful. Oh, blue.
Uh, I am not sure what toolkit means.
Yeah.
Can you just say a little bit more about what that means in this context?
Absolutely. So, what we have sort of talked about doing is creating a, a toolkit. I do have a slide on this that sort of explains what I mean by toolkit later, but I can go into it now briefly if you would like. So basically, we want to just provide guidance to as many people as possible of how to include model policies or how to where to look for information regarding naloxone in the state. We're going to try and have some policy manual, so that's like standardized some of the naloxone rules. I have some conversation with other. This is on this slide. I have some conversation with some folks related to the Oregon State Police, with the Board of Pharmacy, related to expired naloxone, so we can clarify that. It's really just basic guidance related to naloxone. Annalise, you kind of looked like you were gonna add something in there. No? Okay. Great. Or educational resources. So just sort of like a big thing that says we are ADPC. This is the what we suggest related to naloxone. And then when Stacy and Annalise and I were brainstorming about this, we liked the idea of either updating yearly or bringing something related to naloxone, like a new piece of the puzzle something to focus on. So this year we seem to focus on expired naloxone. Next year, maybe it would be updated trainings, or the year after, maybe it would be if there's a new, if people are still concerned about the different types of overdose reversal medications, which one is suggested. So we can put all sorts of things under this toolkit. Does that help? Okay, Annalise.
Yeah, I was just going to add, I saw Haven's note about Save Lives Oregon. I think that's part of what we want to talk about today. So just, a reminder, these all came from you all, right? And it was identified that we had still some barriers that we needed to work on in the naloxone space. Very much heard from you all last time. A lot of those have been resolved. So I think we just have to kind of say, okay, what's been asked and answered and what's been left so we can wrap up this naloxone portion. I don't think anybody wants to duplicate anything that's being done by Save Lives Oregon, but you all said that naloxone was the most important thing to work on here. So I think we just want to wrap up like what does that look like for the ADPC so that we're not duplicating. And if Save Lives Oregon has everything taken care of, then check.
I would say most of the Save Life Oregon stuff is more focused towards agencies distributing supplies and people receiving supplies, and less about some of this policy stuff and like how to create policy, I think that they are different things. I just want to make sure that like it makes sense to be working on it, because I think there is questions about policy and trainings and all of that stuff. So, yeah.
Yeah.
I just don't want us to reinvent wheels that we don't need to.
Yeah, no, we no intention of reinventing wheels. I think that here actually this sort of brings us right back to where we are in this progress about something I focused on in this one was encouraging more naloxone distribution, and by reducing barriers, by coordinating outreach and reducing barriers. So something that was identified as a huge barrier that we have done a lot of work on now is expired naloxone. As I mentioned, I have a meeting with uh, OSP next month to work on a model policy related to donating expired naloxone and what that looks like. And that is something that we can include in the toolkit. I have a meeting with the Board of Pharmacy to clarify some of those rules. Yes, sorry, the OSP is the Office of State Police, not the state prison. um, and because there's some concerns about relation to pharmacy, so I have a meeting with the Board of Pharmacy to clarify some of those rules, and if there comes a clarification or some conversation with other agencies or someone that there is a model policy for that, we can include that. We have heard that there is some potential legislation in the works related to expired naloxone. And so that is another piece of progress that we will keep tabs on and let you know if what comes of that, or where that is ending up, because that is directly related to us. But all of these all of this to say this was a barrier that was identified by all of y'all, and there is work going on, and I know that there is other work going on outside of even what we are doing at the ADPC related to expired naloxone. So I think this is a barrier that, like, this is a really good model of how we can together identify a barrier related to the strategy, and reach in and say, like, here's all of the ways that we can solve this problem, because it's all the way around all these different conversations. So that was a lot. That is the progress so far related to this one strategy in the first 6 months. Does anyone have any questions, comments, concerns? All right, I don't see any. So,
I'll just hop in real
please.
quick, Mara. I mean, I think this committee, you're our newest committee, and I think we're still, and you've had a transition in your chair. And how do I say this? So much shifting policy at the federal level, and affecting funding. And I think it is really amazing that, especially, the new folks who have joined us and the folks who have been here from the beginning, that we just kind of keep trucking along. And I hope that people feel proud of what's been done just in the first 6 months.
Yeah, should be proud. Okay. So, I will continue to work on naloxone access with state agencies and keep y'all informed, asking for guidance when needed. Next month, as I mentioned, we will have a work session to develop the basics for statewide guidance related to naloxone, as we referenced in the strategy, saying that we were going to do statewide guidance. I have also had conversation with OHA and their naloxone communications strategy folks, so that we are, again, not reinventing the wheel, that we are collaborating together so that all of us are putting out the same messaging. There's some updating going on behind the scenes related to different places at the state level that have done work related to naloxone and overdose prevention. So some of that will be updated. I can give you an update on that when I have the names directly of which websites and which resources are in the process of being updated. So that's another update related to this. Now that you've been given all of the updates, and after last month's conversation about opportunities to intervene and barriers still in place, what else? What else? We'd like to switch gears to another strategy. I have some plans to talk about drug checking and a couple of other things later on this year. But what else related to naloxone needs to be addressed? Like what else? Blue.
Um, is is there anything in the works around like Good Samaritan laws becoming more specific around the use of expired naloxone? That was and because it sounds like there's maybe things around a legal pathway for organizations to get rid of or acquire or distribute expired naloxone, but I just wanted to check in terms of like individuals using it and feeling comfortable that they have coverage through Good Samaritan.
Yeah. So, oh, sorry, things just like everything moved on my screen really quick. Yeah, so I think that there are I think that there are some yes. So, as I heard that there is some legislation being brought to the forefront about the Good Samaritan law. We don't know, everything about it yet, and we don't know exactly what it'll cover, and we don't know how far it will go. But yes, we have heard that there is some legislation being brought specifically about the Good Samaritan law and expired naloxone. So I don't have specifics for you yet, but when I do, I will bring them for you.
Okay, thank you.
Yeah. Hayden.
Do you know who's planning to bring those bills forward at this point? Because I'm also hearing like there's also going to be legislation to ban syringe service programs within 1,000 feet of a school that will be introduced. which is going to impact our ability to distribute naloxone to the communities most affected. So I'm really curious if you know who's talking about this and how we can like make sure that those conversations are happening in ways that are most productive.
Yeah, absolutely. So I would say it's coming from our agency partners. So um, uh, when I get Jude back here, she's on vacation, a well-deserved vacation right now. When Jude comes back, hopefully, I think she'll be back next month. I'm hoping that she'll be able to give an update um, on what that legislation looks like and where it's coming from because I talked to her um, about that. So she's who I heard it from. So that is, I will get you more information about that when Jude comes back. Is that helpful, Haven? I know it's not super helpful.
I'll
Well,
call Jude, it's fine.
Okay.
yeah, I mean, Mara, do you also want to add? So Senator Reynolds is going to come in August
Yeah.
to talk to you all about her proposed SSP legislation. So I think that's a really good point of feedback. She is coming to get your feedback as the Health and Safety Interventions Committee in August for her bill, which is the bill that Haven is referring to that would ban SSPs from within 1,000 feet of a school, which is separate from the Good Samaritan legislation. And I'm sure there's other legislation. So hopefully folks will share what else they're hearing.
Yes. We'll try and do a little heard through the grapevine legislation uh moment this summer. I see Crescencia.
Thank you. I just wanted to just state what I'm hearing in the community about the naloxone Narcan. And I don't know if this will be part of the education portion or what, but some individuals and community members were stating that the naloxone may not be strong enough, and I don't know if that's like I've been asked if there's higher doses of naloxone and are the injectables different than the nasal spray, and so if there's like maybe we want to I don't know if this is part of the educational portion, like education and information around the naloxone. I know that some individuals who administer naloxone, there's steps that are not being taken, like maybe the breathing for them and stuff like that, or maybe not doing the administering the 2 minutes apart. But just one of those, just wanted to bring that up if maybe that's something that we did want to work on, getting more education out there to the community so they understand what's going on with the naloxone and why it might not work versus when it did work and if higher doses are needed.
Absolutely. That is really helpful because you are not the first person that I've heard say that. So I think the clarification on administration and like what is, best practice when you administer naloxone and that is really helpful. Definitely something we can include in our toolkit and has something that has been brought up in the conversations that I've had with OHA about updating their resources. So that is awesome to hear that that's something that's concerning all the way around. I mean, it's not awesome that it's concerning, but you know what I mean. This is great for me to hear. Thank you, Crescencia. Serafina.
Yeah. Oh, so much to say. So for Sensi, I just want to respond to that first. I know I've seen some things in the chat. Haven, myself, and all of us that have done work and looked into some of the Save Lives Oregon material have had questions around these same exact subject areas. And I know we do have some additional information, so I would love to share that with you. And I know Haven has given you the opportunity to reach out, and she's just such a wealth of information herself. But we've dealt with these same exact questions, and I think education is such a big part of it, and it needs to be discussed on a wider scale. The reality is that a higher dose only creates worse withdrawal symptoms. And there are methods that we can use, like breathing, which you brought up, that are so effective and help to reduce issues as people come back from that overdose. In addition to that, I think, I think we need more education around the intramuscular for a lot of individuals as well. And really creating some educational videos around that and training that on a wider scale is a need. So thank you for bringing that up. And I'm always happy to chat with you and connect, you know that. One piece that was brought up for me around naloxone education and things that I see in rural communities and throughout is additional education for EMS, because we see long response times and we see a lack of education. And even within work with rural fire departments, there's just such a lack of education, and they're expected to do so much. And all of the work that we do has its challenges. And I think when we share the knowledge we have around naloxone, I've just seen hearts open up and communities stand up and really create that change where it's needed most. So if we can lend some education in the sharing of education within the medical field, EMS, firefighters, all first responders, that's huge for me, and I think for all of us.
I love that. That is really important as well. And, related to, I think, more than one of our strategies as well, because there was our naloxone strategy, and then our fourth strategy under our committee was cross-sector education. So I think these messaging tools and our cross-sector education, like that just aligns all of these things. So thank you for bringing that up, Serafina. I really appreciate that. Okay, so I've heard a lot of, we're still interested in hearing more about expired naloxone. That is still something that we want updates on, and we still want to move some things forward related to expired naloxone, which is definitely on my list. And I've heard educational clarification. So, making sure that we have up-to-date best practice, and making sure that the people who need to know the best practice know the best practice. Special focus on rural areas and other first responders other than law enforcement. What else? What else do we still think is a barrier or an opportunity to intervene? Uniformed first responders. Got it. That makes sense. Haven, thank you for sharing that. The uniformed first responders the first responder is the person calling for the uniformed responders. That makes sense. That makes sense. Annalise.
I wanted to ask a question. Crescencia, I thought about it when you were talking, but also kind of for everyone. Somebody I can't even remember now, maybe it was you, Serafina, mentioned like videos. What are the best kind of ways to go about, educating the broader public, educating uniform first responders? If folks have particular thoughts on kind of how to get this information out.
I mean, I'll share. I think we need consistent education, but there is something to be said for tailoring what we're doing to the individuals that we're trying to get that material to, right? So having that consistency, but I think making that known in a variety of platforms from diverse individuals from a variety of backgrounds, because I do think there are people who specialize in naloxone, have used it a lot in all of these different fields, that the people that work with them might be more receptive to hearing the information from. As a community-based organization, we're able to reach a lot of people and have that broad kind of outlook, but what we do know is that bringing in professionals from the community that serve that community, that have lived in that community or been a presence in the community, really speak in a different way. And so I think, you know, having access like on the web and videos accessible, but in addition to that, incorporating that into the local kind of area. I hope that helps.
But
Yeah, I think like using peers as much as possible, and I'm using that in the broad sense, like, you know, people with lived experience of drug use may be more helpful when we're educating other people who use drugs or who may be around people who use drugs. But if you're, you know, speaking to pharmacists, you may want to find somebody that is a pharmacist, you know, and just making sure that you have somebody that whoever, you know, you're training can relate to and understand, you know, the language that they're using, because that can definitely vary.
even
Well, I mean, just this may seem really blunt and like a big hammer for this, and that, like, as much as I want to believe that like people want to learn this stuff, I think unless we tie it to some kind of credentialing and licensure, people aren't going to do it. So, like, honestly, I would be looking at like, can we make the board of pharmacy have it be a requirement that people are trained on naloxone? Can we make the state police force like do these, like, I don't, people aren't going to do it just because they want to or it's the right thing to do, because we're busy and we're trying to juggle. Like, that's not a slam on anyone, it's just more like, can the OLCC require it for anyone who does X, Y, or Z or sells X, Y, or Z? um I think we're going to need, yes, I agree with all of the things that, like, a firefighter is going to be able to train other uniformed first responders better than I could. But I also think looking at what kind of requirements could be added may be the only way to actually achieve this goal.
just checking out the chat. Thank you. That's actually really helpful. I think that that is, I mean, these things are helpful to know in the conversations about, you know, with the agencies. Helpful to have that information, that this is the desire. So I'm seeing that it is now yearly mandatory training for OYA with it from Katie Johnson, how to be trained officially for OYA, the Oregon Youth Authority, as a clinician. So seems like there's already some of this going on. Katie, I might reach out to you to see if there's like a model policy there. That would be something to include in our toolkit. So that would be awesome. Awesome. Great to hear.
I was going to say for HIV Alliance, it's a yearly mandatory training now. And not only do we need to be trained on how to do this, but we also have to be trained to train others as we're handing out naloxone. And that's like nasal and IM. So
That is good to know within the like the community organization realm. That's good to know. It sounds like there's some of you are, I'm seeing a lot of like nodding heads, like that's relatable for other folks as well, that, within your organization, that's the standard. I love that. Okay, that's great. Every year staff, LCSWs, Yep, okay. I love that. That's great. That's fantastic. So, relating naloxone training to licensure potentially, or something along those lines. Um, and it sounds like what I heard earlier was like peer to peer in like the grander sense rather than like the licensed peer version. Slash like local champion is like a great method for training. That's like a preferred method that we've found is successful with this. Great. Okay, I'm seeing nods. Fantastic. Um, what else? Is there anything else that you think that we haven't talked about related to naloxone that you think needs to be brought to the forefront so that we can either include it in our toolkit or keep conversations about it, or that's something that I need to go and do some conversations with specific people about? What else? Mariah.
So maybe this is just our community, but it is one of the biggest situations where people relapse in this community, and our jail does not hand out naloxone upon release. We actually just had two people last week overdose because of that. They overdosed when they got out, and it's because, as an addict, we pick up where we left off. And so maybe education or access to naloxone for like the justice, like the jail services and stuff. Maybe it's just our jail, I don't know, but I just know that that's one of the biggest causes of overdoses in our community.
Yeah, yeah. That the carceral settings, that's important. I know that some of the other committees have been doing some work directly with the jails and prisons related to, yeah, Haven says it's not just your jail at all, for sure. Yep. Um, vending machines, I'm seeing in the chat, potentially vending machines. Yep. There is discussion about vending machines, no locks boxes, like wider network, increased access of no locks boxes. I love all of these ideas. This is something, this is definitely something, Annalise, I think that I can follow up on is, jails and prisons. As Mitch here, we've had some conversations with some of the jails and prisons folks related to treatment. So
Yeah, I mean, I was just thinking, Mara, I mean, not every jail takes the jail MOUD funding, but the majority do. And so I mean, that's a potential conversation with CJC to write that into their grants to make sure. I mean, probably most the jails that are taking the MOUD grants are probably the ones that are including naloxone on release. But anyway, that has been widely popular. Another thing I'll just throw out there for this committee to think about in terms of kind of those local barriers. We have started to increase I mean, this is very nascent, but outreach and collaboration with local alcohol and drug planning committees. It's something that's required under state statute that really nobody's ever really done much. So we did a survey recently of the LADPCs and starting to talk to them. One thing we have talked about doing is to do kind of like a local toolkit for the ADPC comprehensive plan. Like, here's things that you should assess in your community and strategies that you might want to think about. one thing is to kind of, in addition to this toolkit, really pull out these things that are local barriers that folks are seeing that we could give to the LADPCs to say, hey, when you're evaluating or doing an environmental map, these are things we really need you to be checking on. I don't know that I don't know. A lot of these LADPCs are really focused on their community providers and not so much on transition out of carceral settings or with their jails. Some are and some aren't. So I'll just throw that out there that that's another thing for you all to think about as a way to kind of get into all the local communities to make sure that this is available everywhere statewide.
Love that. That is really good thing to bring up. All right. Okay. So, obviously this is not the end of this conversation. This is a strategy. These strategies are things that we are going to be working on for the entirety of our 5-year plan, right? So if something does come up and you say like this is, there's a new barrier or there's a new um, uh, resource or something that you think is a good idea, please always send them my way. It's really helpful for me to have all of the information that you guys have because I get some pieces, you get some pieces, we're all trying to do this together as a group. So that is super incredibly helpful for me to have that. Let's see. So, as I mentioned, next month we're going to be doing a work work group about what should be included in the toolkit. So what I would love for you to do is I would love for you to do some brainstorming related to what should be included in the toolkit. And it is I do have like a basic outline listed in the slides, and I will, after this meeting is over, write a big old email that has, the what's included in a toolkit, what I'm hoping to get from you, and what I'm hoping to do with our time next time, so that you will have it, so that we can do that next time. So that is going to be your homework, and hopefully either sending it to me prior so I can include it, or bringing it day of with suggestions, and then we'll put something together for all of us to react to, and hopefully when our dear friend Stephanie comes back, our comms person, when she comes back, she'll help me out how to distribute it and where to put it and how to make it look pretty. So that is sort of like the path there. If you're not, you will not be left alone with no direction. I will send you an email with all of this information in it so that you don't have to so that you have to think about me after this meeting. Yay.
I don't know if this is possible, Mara, but it might be easier for you and for all of us if we do like a shared doc, like a Google Doc that like, because I can imagine most of us have a lot of similar ideas.
Mhm.
And so like just am I making sense? Does that make sense? Just
Totally.
like a shared doc that we can all add to, dump on, and then you won't be collecting emails from 15 people trying to do that work on the back end.
Totally. I will do my best to figure out which or which company I can use their shared file. And if I put in a shared document and you can't access it for whatever reason, because this has happened with different folks, is you can just send me an email. So that is a great idea, Haven. Thank you. And it does reduce the duplication of work and ideas. You're right, Jenna. Thank you. Yeah, I will do that. But all ways of getting things to me is okay.
And can I ask a quick question on that, Mara? I mean, I think this is a really productive conversation, but I did hear kind of two maybe like buckets. That one is like TA, kind of along the toolkit, TA education. And I agree 1,000%. When our communications person gets back, she's going to be super excited about this. For folks who don't know Stephanie, she likes to do video work. Like, I think we have, like, this is why we brought this person on. But I'm also hearing there's like policy suggestions on how to take this forward in terms of like local policies and required trainings. Is that kind of the direction that you're trying to get here? Like that you're for the homework, is the homework just like for TA, or can folks also put like policy ideas in there as well?
Yeah, I mean, I am always open to receiving any kind of information, so policy or TA. I was thinking specifically um, for the toolkit, it would be more so like if you have like a model policy, so more in the TA side, because this is sort of my view of this is like a big space where all of the things can be in one spot, and we can, bring things to the forefront and say like, hey, this is the toolkit that ADPC put together through, all of this, and here's the links to the places that we want you to go to. Here's, the up-to-date information. Um, and but I will put a little section in the instructions and the shared document if there's any like policy recommendations or things like that you would like to share, then I am happy to hear them and see if that's something that we can um, put our fingers into. Cool, awesome, amazing. So, because we've had such a really good conversation about all of this, and I think that we are in a really good spot. I would love to move us on to agency partner updates. If any of our agency partners, state agency partners, have any updates for this group, I would love for you to come off mute and share them. Who do I have? If Anne or Orion or Bailey has any agency updates for us, that would be awesome. And
I
I
was
don't,
gonna say, the only difference is funding's been cut, and due to us getting SAMHSA funding for peer support, we're no longer able to do the harm reduction that we really value to do. So that's our HIV Alliance and the peers.
thank you. I'm seeing not at present. Thank you very much. None on my end this morning. Great, fantastic, awesome. And if you weren't here, our agency partners earlier, I mentioned that I've built in some time for agency partners to do updates for us every month. So you are always welcome to come and share updates with us. Okay. I know we are just a little bit early, but I don't think we have time for a move on. So, Ashley, have we received any public comment, request for public comment?
We have not received any public comment or request.
Okay. Is there anybody else who would like to say anything else before we? Yeah, yeah. I'm always happy to give you time back, Haven. Any of our voting members particularly that have anything they want to share with us?
I actually just had a question. I heard you briefly mention drug checking earlier. Like, is there an estimated month that you think we will be able to pivot and maybe start putting some attention towards that?
Yes. My uh this is an estimate, so do not quote me on this. My estimate is September, October. That is my estimate. We have the next at least 2, potentially 3 months full of wrap up and um, updates related to things that we've talked about previously. So September, October is what we're looking at. And then we'll do sort of like a landscape analysis at that time. Is that helpful? Beautiful. Okay. I do not see or hear anybody else who would like to give comment. Yep, give us time to see how the Fed stuff shake out with drug checking. There's some stuff related in November that we're going to see how the bill goes, the HB1 goes through, all sorts of things related there. So we will see all of those things. Always, as always, more to be revealed. Okay, if there is nothing else, if you have any questions, comments, concerns, or pictures of dogs, please feel free to send them my way. Thank you all so much for your time and your dedication to this work. It is really appreciated. And I will see you next month and look for an email from me with instructions and a Google Doc or something similar to build our toolkit together. Yay. Awesome. Thank you all so much. I'll see you.